Hello everyone, welcome to Anesthesia School. I am Ruslan. Today we are presenting our third video in English. We will be discussing the anatomy of the internal jugular vein and central catheterization. This is one of the first skills learned by anesthesiologists and intensivists. It is generally a simple technique, but its complications can be severe and we must be mindful of them. I said generally easy, but sometimes we encounter patients with very different anatomy, especially pediatric patients who are sometimes too small or patients who have developed numerous collateral vessels. However, today we will talk about the very basics of this procedure. Without further ado, let's begin. I hope you enjoy it. The internal jugular vein is typically used for short-term central venous catheterization. As with any intervention and procedure, knowing the anatomy is vital because complications arise accordingly. It is one of the most fundamental techniques an anesthesiologist or intensivist should know. While it is good to know various techniques, I recommend choosing one and mastering it in full detail, being in complete control of every aspect of that technique. Let's look at the anatomy. Those who watched the cerebral circulation video will remember the internal jugular vein is actually a continuation of the sigmoid sinus. It exits the skull through the jugular foramen. The jugular bulb is also located in that region. It joins the subclavian vein behind the sternoclavicular joint. It is situated within the carotid sheath along with the carotid artery and the vagus nerve. From top to bottom, it is positioned first posterior to the artery, then lateral, and finally anterolateral to it. Let's now look at the tissues the needle passes through during the cannulation. First it is skin, then the subcutaneous tissue, then platysma, then the sternocleidomastoid muscle, and finally the carotid sheath fascia, before puncturing the vein itself. Regarding anatomical neighborhood, anteriorly there are the internal carotid artery, in the cranial portion of course, and the vagus nerve. Posteriorly, the lateral border of the C1 vertebra, prevertebral fascia, vertebral muscles, cervical transverse processes, the sympathetic chain, the pleural dome, and the thoracic duct, which is only found on the left side. Medially, there are the carotid artery and the cranial nerves 9, 10, 11, and 12. So, why do we need a central venous line? The first indication that comes to mind, and a long-standing one, is the assessment of the patient's fluid status. The pressure here indicates the hydrostatic pressure of the great veins of the thorax and the right atrium. The large veins of the thorax, abdomen, and proximal extremities form a reservoir. This is also called the capacitance system. This reservoir accounts for a massive portion, nearly 2/3 of the body's total blood volume. However, as I mentioned at the beginning, this also depends on the right ventricular function. Therefore, in the right ventricular dysfunction, there will be high filling pressures, regardless of the fluid status of the patient. Normal values are around 0 to 8 mm mercury. Sometimes it can drop to subatmospheric levels. For example, this could be due to a measurement error if the transducer is placed above the level of the right atrium, or due to high negative intrathoracic pressure, as seen in an asthma attack. Other indications include pulmonary artery catheter placement, hemodialysis or hemofiltration, transvenous pacing, and certain drug administrations. It is especially necessary to administer some cytotoxic agents and vasopressors or inotropic agents through central line. Otherwise, venous irritation, phlebitis, and extravasation may develop. TPN should also be given centrally unless it is peripheral one. The main determinant here is the osmolarity of the solution, and those above 900 milliosmoles per liter must be given centrally. A rare indication is the treatment of air embolism, which is very difficult to apply in practice but still included in some algorithms. Moving on to the technique, it is practical to know one technique in full details. Nowadays it is performed using ultrasound in most places. However, it is also necessary to know landmark-based techniques. This might appear as an exam question for you or save your day in a resource-limited environment. Landmark-based techniques can be done via middle, anterior, or posterior approach. Usually the middle technique is used, the classical one, the entry between the two heads of the sternocleidomastoid, aiming towards the ipsilateral nipple. We won't discuss the technical details here. Many training videos are available today. I'm just leaving one of them in the description section below for you to check, and you can also see the reference below on the screen here. We frequently use the Seldinger technique, presented to us in the 1950s by Ivar Seldinger, a Swedish radiologist. We commemorate and thank him here. Besides the internal jugular vein, other cannulation sites include the subclavian, femoral, median cubital, and basilic veins. Catheters inserted from these latter ones are called PICCs, or peripherally inserted central catheters. Let's say a few words about the subclavian vein. It is located between the outer border of the first rib and the medial border of the anterior scalene muscle. It joins the internal jugular vein to form the brachiocephalic vein on both right and left sides. The clavicle is in front of it, the subclavian artery is behind, and the pleural dome is inferior. Regarding the complications of internal jugular cannulation, they are accidental or inadvertent arterial puncture, or worse, the cannulation of the artery, pneumothorax or hemothorax, intrapleural placement, chylothorax, which is on the left side, air embolism, arrhythmia, and infection, mostly caused by coagulase-negative staphylococci, Staph aureus, enterococci, and pseudomonas. There are practice guidelines for central venous catheters, the most well-known being from the NICE and ASA. They are updated periodically. I'm sharing the current ones here and will put the links in the description for you to check. The ASA guideline was updated a few years ago. It's extremely detailed. It discusses proper resource management. It includes recommendations for asepsis rules to prevent infectious complications, the use of antimicrobial impregnated catheters, selection of catheter insertion sites, catheter dressing, and duration of catheter use. There is also a separate section on preventing mechanical trauma and injury. It provides very detailed recommendations regarding the insertion site, patient positioning, needle entry, advancing the guide wire, catheter placement, and confirmation of its place. In fact, since different disciplines insert or follow up central venous catheters, many societies have developed clinical practice guidelines, such as Society of Critical Care Medicine, European Society of Intensive Care Medicine, CDC, which I forgot, I'm really sorry, you have to check in the internet, and INS, that is Infusion Nurse Society, and some others, of course. They basically recommend similar things, using ultrasound for internal jugular vein whenever possible, and taking maximum sterile precautions, which include a cap, mask, sterile gown. So it is not only about the gloves. So you have to be completely sterile to perform this procedure. Recommendations also include using chlorhexidine for asepsis and implementing protocols to prevent catheter-associated infections. That's all for today. Thank you for listening. See you in the next video. Goodbye for now and have a beautiful rest of your day.